bacterial infections like tuberculosis, viral infections like HIV, and it can be because of malignancy or some other connective tissue disorders. So here it is, apart from infections, we need to consider malignancy and connective tissue disorders also. So coming to antipyretics, what to use if children have fever? So we need to use either paracetamol or brufen in children who appears distressed. Do not give antipyretics with the sole aim of reducing temperature. Now the child may be having 100.5 degrees, child will be playing. So what are we trying to achieve? So we should not give antipyretics just to reduce the temperature. If the child is having some discomfort like extreme myalgia, fatigue, then we can give paracetamol or brufen to decrease temperature. Our aim of giving antipyretics should not be solely to decrease the body temperature. Sometimes the combinations are available, brufen plus paracetamol. So we should not give both the agents simultaneously. If you calculate the dose, none of the dose will come appropriately, and it should not be used simultaneously. If there is no role for nimesulide or mefenamic acid in children, kindly please avoid NSAID for children. So antipyretics do not prevent febrile convulsions, and it should not be used solely for the purpose. So parents, once the child gets febrile seizure, next time even complete fever, 98.8 degree also, they will get jittery. And they start using multiple antipyretics. So that should not be every time. We need to counsel the parents like giving antipyretics are not going to prevent febrile seizures. So they should not be very anxious about fever. So
ma'am, unmute yourself, Dana ma'am. Somebody is taking, and for the kind information of all of you, I have posted the YouTube link. You can please communicate to all your friends.
When it was unmuted?
Hello. And now it is unmuted, madam.
No, I can start continuously or I need to go back?
Ma'am, you can start, madam. Please start.
No, the same slide you can start.
Okay. So antipyretics do not prevent febrile convulsion and should not be used solely for this purpose. So what about the physical measures? Can we apply some physical measures to decrease temperature? No, I am not able to move my screen. Yeah. So tepid sponging is not recommended and children should not be overdressed or unwrapped. So we have seen about oral antipyretics. So what about rectal or IV paracetamol? So rectal and oral paracetamol, they are comparable with respect to temperature reduction. So concerns with respect to toxic effects and unpredictable pharmacokinetic and pharmacodynamics due to poor and erratic absorption is noted if paracetamol is given perrectally. So please try to avoid giving perrectal paracetamol. So we stopped using suppositories for a long time. So in our hospital, we are not giving perrectal paracetamol for more than 10 years. So it has an unpredictable pharmacokinetic and pharmacodynamics. So they say time to achieve the peak concentration is little bit delayer than oral paracetamol. So there is no point in giving perrectal paracetamol when compared to oral paracetamol. And what about intravenous administration? A single dose of intravenous administration is equally effective and safe when we are not able to give orally. For example, post-operative child may be kept NPO. So we are not able to give oral paracetamol. In that scenario, we can use 1 or 2 doses of intravenous acetaminophen. Otherwise, routinely, it should not be used. So oral paracetamol is more than enough in bringing down the temperature. So we will move on to the case scenario. First 4 case scenario will deal with acute short duration fever. These will be taken up by Professor Dr. Rajkumar. So first case, here it's a 1-year-old child who presented to us with 2 days of high grade fever. It's moderate grade fever, 103 degree Fahrenheit. Interfebrile period, child is lethargic. It's not active as before and has associated vomiting also, which is non-bilious and non-projectile. No other localizing clues for fever. On examination, the child is hemodynamically stable. System examinations.
Time 5:30 ஆகுது.
Dr. Rajkumar.
Hello.
What will be your differential diagnosis and how to differentiate viral and bacterial illnesses clinically?
Thank you, ma'am. Am I audible, ma'am?
Yes, sir.
Vendre dress matte. Face wash பண்ணிட்டு கை கால்.
I don't know, somebody is talking.
Dr. Uma Devi, ma'am, please mute yourself. Request all to see that it is all your audio is muted.
Thank you, ma'am. Good evening, one and all. Actually, a case in day-to-day practice, actually a diagnostic dilemma, especially dealing with by it's called fever without source. And this fever without source patients, usually majority of them, they'll have a self-limiting mild viral illnesses. Now, they said by studies they found out adenovirus, herpes virus 6, enterovirus, and parvovirus. They are the cause for this fever. But a minority of children with fever without source, they'll have a serious bacterial infection, SBI. Mainly, they said UTI, but sometimes it might be pneumonia or a sepsis, meningitis, osteomyelitis, and septic arthritis. Over to you, ma'am.
Yeah. So usually how we classify clinically is usually viral illness of high grade fever at onset and better by day 3, day 4. Biphasic pattern is possible. Classical example is dengue. In this season, if the child presents to you with 103, 104 degree Fahrenheit, then you think of dengue as a first differential diagnosis. Then usually fever settles down by day 3, day 4. Again, it can recur after 48 hours. How the bacterial illness behaves, it's usually moderate in onset and then later on it used to peak. The other clues for differentiating viral and bacterial illnesses, usually children with viral illness, they are non-toxic. And interfebrile period, they will be totally normal. There is a multi-system involvement. There may be running nose, there may be diarrhea. So the multiple mucosa is involved. More than one family member is affected. Classical example now is COVID-19. And one more thing is seasonal variation. If it is in winter season and the child presents to you with 2 days of fever, we always think of viral illness. On the other hand, in a bacterial illness, the child will be totally toxic. And interfebrile period, the child will not be normal. Child is lethargic. And usually it is localized to one system. You take a typical example. If it's a typhoid fever, the child will have localizing symptoms to abdomen. Child will have vomiting, diarrhea, or constipation. And there will be no sick contact in the family. So this is how clinically we differentiate viral and bacterial. So apart from the height of fever, how the child is behaving in between the fever spikes, it's more important. Here the child is not well in between fever. And the one more important differentiating, so fever without source. So here it is mostly viral and few percentage of them will have UTI also. We should not miss. So if you see a child with temperature more than 102 in your clinic, if especially in children less than 2 years, then it's always better to do a urine routine. So we are ordering an urine routine. So, sir, how will you react to this urine routine, sir?
Hello, ma'am. For diagnosing UTI, ma'am, actually,
Yes.
okay, ma'am. Actually, in older children, the children may come.
Hello?
Rajkumar, sir.
Hello? Okay.
Dana, ma'am, I think you
Yeah,
can
yeah.
take up. Please drop
Yeah,
it.
yeah. So urine routine.
With
So
classical
urine,
signs of urinary tract infection in the children. Yes, ma'am. Hello.
Rajkumar, sir, your audio is breaking. Can you please put your video off so that we can hear you? Your voice is breaking a lot. Yeah. Now you can start from the beginning because we were not able to hear what you were telling.
Okay. Actually, the criteria for diagnosing UTI actually. So fever might be the only sign of urinary tract infection in young children and as well as in infants, ma'am. Actually, in older children, they may come with dysuria and classical signs of UTI, but in young infants, it might not be there. So we have to order whenever we have suspicion, especially if there is a previous history of UTI, when the temperature is more than 39 degrees centigrade for lasting for more than 48 hours, or if the day one, if they come with 40-degree fever, or child looks very sick and ill, especially less than 2 years, we have to order urine analysis as well as urine culture, because urine analysis might not be enough sometimes. Here, the nitrate is absent here, ma'am. Actually, this may be because it's a false negative one, because what happens, the nitrate test to be positive, the urine has to remain in the bladder for at least for 1 to 2 hours. The bacteria has to reduce the dietary nitrates into nitrites. So the nitrate test may be false negative sometimes. So we have to order urine culture in these individuals less than 2 years. So urine culture, we have to order for toilet trained children, we can ask for midstream clean cat sample, but for older children, who are younger children who are not toilet trained, we have to either go for catheterization or suprapubic aspiration. And how to, ma'am, shall I continue?
Yeah.
Okay. How to identify significant bacteria in plain voided sample? If there is a growth of more than 100,000, 1 lakh colony forming units of a single uropathogen, then we have to come to a conclusion that this is UTI. And for cathedral sample, if the growth is more than 50,000 of a single uropathogen, then it is okay. We can call it as UTI. And from suprapubic sample, even one growth of any uropathogenic bacteria, that is one colony on the plate, which is equivalent to 1,000 colony forming units per ml, we have to call it as UTI. Over to you, ma'am.
Yes. Right now, we are not ordering a suprapubic urine aspirate, but we are getting a catheter sample or a clean catch. If it's a toilet train, as he rightly pointed out, we can do a midstream urine specimen. Otherwise, just ask for a catheter sample and order for a urine culture. And one more thing is, always don't forget to get the urine dipstick. So the LE nitrates, that is leukocyte esterase and nitrates, will give an important flow. So when you combine all these three, leukocyte esterase, pyuria, and nitrate, the sensitivity of diagnosing UTI goes up to the tune of 99.8%. And if all the three is negative, you can safely rule out UTI also. To rule in and rule out, these three are very, very essential. So whenever you order for a urine routine, you make sure that leukocyte esterase and nitrates comes in the test. And before ordering for a urine routine, you have to give clear instructions to the mother how to clean the genitals and how to collect midstream. And one more thing is, it has to be transported to the lab immediately, or within half an hour, it has to be plated. Otherwise, you would get a false positive. So these are the instructions you should give to the mother. Otherwise, she will do a bag specimen collection, and then sometimes they will do a urine culture from that. So bag specimen is not recommended for doing a urine culture. So it is always preferable to get a midstream urine and then proceed with the culture. So now we are suspecting urine routine is suggestive of probable UTI. We have ordered for a urine culture. Meanwhile, we should start our antibiotic. So what is your empiric antibiotic of choice? Whether you are going to start an amikacin, ceftriaxone, or ceftriaxone plus amikacin, or piperacillin tazobactam, or ceprofloxacin. What is your choice, Dr. Rajkumar?
Okay, ma'am. Actually, we all know that urinary tract infections usually are caused by gram-negative organisms. E. coli, it's a topper actually, and Klebsiella, Proteus, Enterobacter, and Citrobacter, they come after E. coli. And all these organisms, they respond very well, excellently to aminoglycosides like gentamicin or amikacin, as well as cephalosporins, third generation cephalosporins, cefotaxime or ceftriaxone. So here, in a child like this, come from community, it is come with UTI. I will go for, if the child is very sick, I will admit, and I will start either amikacin or gentamicin, aminoglycosides.
Okay.
Of course, the definitive therapy will be based on the results of urine culture and sensitivity when it comes after 2 days.
Okay. So as you rightly pointed out, E. coli is the commonest organism. But before we start an empiric choice, we should know our community antibiogram susceptibility. Okay. So otherwise, you can at least rely on the national antibiogram also. So here in India, especially in our part where we are practicing, so we see a lot of E. coli are ESBL producing. What is ESBL? It is an extended spectrum beta-lactamase producing organisms, and they are usually resistant to third generation cephalosporins. So here, based on your local antibiogram, you can choose your antibiotics. Since our isolates are 70% resistant to cephalosporin, we always go with piperacillin tazobactam. And based on the sensitivity, suppose if it is sensitive to ceftriaxone, then we will de-escalate. Otherwise, we will complete the course of antibiotic. And one more thing with respect to aminoglycosides is for bacteremia, it is not the ideal drug. So amikacin monotherapy in a sick child is not recommended. So usually you start with a beta-lactam antibiotic. Once you know it is sensitive to amikacin and the child is stable, there is no bacteremia, then you switch to amikacin. So one more disadvantage with amikacin is it has a significant nephrotoxicity also. So we should know the underlying renal function, any underlying structural anomalies we need to rule out before starting amikacin. It is always start preferably with a beta-lactam antibiotic. Then based on your sensitivity, we can de-escalate. So if the ceftriaxone is sensitive in your part, then you can start with ceftriaxone. Otherwise, in our area where ESBL is more than 70%, we start with piperacillin tazobactam. And regarding the fluoroquinolone sensitivity is gone. Please don't use fluoroquinolones for UTI. So these are the carry-home messages. So this is how our urine culture report comes. So this is E. coli isolated, 10^5 colonies. So as we rightly expected, third generation cephalosporins are resistant. So this is called ESBL E. coli. So that's why they mentioned this ESBL producing organism. So here our choice is BLBLA, that is beta-lactam, beta-lactamase inhibitor, either piperacillin tazobactam or cefoperazone sulbactam. So these are ideal drugs. And we have ruled out bacteremia. If the child there is no growth in the blood culture, then you go for amikacin. So because we need to give duration of minimum 10 to 14 days if it is a pyelonephritis. So amikacin sensitive, any other oral antibiotic, cotrimoxazole is sensitive, gentamicin sensitive, meropenem sensitive. So we till the child receives there is a resolution of fever for at least 48 hours, then you switch to oral antibiotics like cotrimoxazole. So ordering an urine culture is very important, and know your local antibiogram before you choose your empiric antibiotics. And aminoglycosides, no upfront as a first line, don't use aminoglycosides. This is for UTI. Then the second case scenario, this is a 2-year-old child presented to you with fever of 4 days duration, has vomiting loose stools for 2 days, rashes for 2 days, and the child is totally lethargic and toxic. There was red eyes, but there were no purulent discharge, had shock, hemodynamic instability at admission. And the basic blood counts, total count 14,200 with the polymorphs predominant 92%, platelets are borderline low 1.4 lakhs, very high CRP2 34 milligrams per liter, hyponatremia, sodium is 122, urine again shows pyuria 10 to 15 parcels, X-ray normal. So for blood culture, there is no signal after 48 hours. So how to approach this child? What are the differential diagnoses you consider when you have a case scenario like this?
Okay, ma'am. We are living currently in a COVID pandemic for the last 2 years. So whenever we come across a child with fever for more than 3 days and who is having signs and symptoms of multiple organ involvement, especially GAT, cardiac, skin, neurologic, and respiratory, our first diagnosis will be MIS-C, ma'am. That is multi-system inflammatory syndrome in children. Unless otherwise proven, that is my diagnosis. And we have to confirm the diagnosis of MIS-C by doing a battery of investigations. The panel for inflammatory biomarkers, CBC with the differential count, CSR, CRP, ferritin, LDHD, etc. And of course, but the most important thing is we have to roll out the close DD, the mimics, the MIS-C mimics, the infections caused by the toxic shock syndrome by staphylococcal and other things. So the close mimics, shall I continue, ma'am?
Yes.
So my diagnosis would be MIS-C, but we have to look for the mimics for MIS-C, ma'am. So the first mimic I will look for is the Kawasaki disease, ma'am, KD. Almost 50% of the children with the MIS-C, they will meet the criteria for complete or incomplete KD, ma'am. With shock will be indistinguishable from KD with shock syndrome. So how to differentiate between these two? So we have to look at the age group, ma'am, actually. The MIS-C commonly affects older children and adolescents, while KD commonly affects infants and young children. Then look at the system involvement. If the child has more of GAT symptoms like abdominal pain, diarrhea, and vomiting, which are common in MIS-C, and myocardial dysfunction and shock, again, it's common in MIS-C, while KD, the involvement, the GAT and myocardial system involvement will not be there. Then look at the inflammatory biomarkers, ma'am. We have to, so the CRP, ferritin, and D dimer, they tend to be more elevated in MIS-C. The CRP will be, it's like more than 100, it may go up to 200. Then looking at the lymphocyte count and platelet count, it will be the absolute lymphocyte count will be lower in MIS-C, as well as the platelet count also will be low in MIS-C than in KD, ma'am. The second diagnosis would be the infections, especially the toxic shock syndrome due to staphylococcus and streptococcus. The clinical features of toxic shock syndrome are almost, again, indistinguishable from MIS-C. We have to do blood culture for any child which comes with blood and urine culture, as well as other body fluid culture for any child who comes with MIS-C, because microbiological testing is the only way out here. We cannot clinically distinguish. So that's why every child with MIS-C must be given empirical antibiotic till we get these results. Then the third diagnosis would be bacterial sepsis, especially in infants and small children like this, due to pyelonephritis or any other infection. So that also may closely resemble MIS-C. We have to actively look for the primary source of sepsis by doing appropriate imaging studies if needed, and microbiological test also will differentiate sepsis from MIS-C. And the fourth one, infections due to viruses due to like dengue shock syndrome. In our part, it is very common. That also may closely mimic MIS-C. And a rickettsial infection like strep typhus, especially we are seeing them in Madurai and area. We are seeing a lot of strep typhus that they're coming with the multi-system multi-organ involvement. That also may closely resemble MIS-C. So we have to order appropriate investigation and examination, and we may have to put empirical drug therapy against this strep typhus. And finally, now last but not the least, HLH, the hemophagocytic lymphohistiocytosis, might also closely resemble that of MIS-C. We all know that they are symptoms of excessive immune activation. So the clinical features and lab markers will almost resemble that of MIS-C. Only thing which is going to differentiate HLH from MIS-C would be these HLH children will be acutely ill with cytopenias, and the liver and CNS involvement will be more than GAT and cardiac involvement. Over to you, ma'am.
Thank you, Dr. Rajkumar. So now we have a KD as an important differential diagnosis. So whenever you encounter a child with multi-system involvement, like a GI involvement rash, we always should think of MIS-C nowadays. And the MIS-C and KD treatment aspect and follow-up, it is going to be the same. So only the labeling is important. So if there is a history of COVID contact and the COVID IgG, IgM is positive, you are going to label as MIS-C. If these are not there, then you are going to label as Kawasaki. Both the treatment, IVIG and steroid, and further follow-up, everything is going to be the same. And we had so far around 150 cases of MIS-C when we analyzed the presence of rash associated with the shock favors more in more of MIS-C, and the presence of hepatosplenomegaly. If there is hepatosplenomegaly and there is no shock and the children has multi-system involvement, then you think of other tropical infections also. So usually hepatosplenomegaly will not happen in MIS-C. And if the child presents with a rash and hypotension, then you always consider MIS-C as your first differential diagnosis. So moving on to case 3, here a 9-year-old male child vomiting, fever for 1 day, headache and neck pain, preferring to sleep more. There is no history of seizures. When you examine the child as GCS of 15/15, where there is a significant neck stiffness, turning sign is positive. There is no cranial nerve involvement. There is no focal deficit. So what is the differential diagnosis? How will you approach this child, sir?
Okay, ma'am. Straight away, I'll diagnose it as a case of acute bacterial meningitis, which is a medical emergency and which deserves early diagnosis and aggressive therapy. Yeah. And the choice of initial antimicrobial therapy would be based on the most common pathogen we encounter in our particular geographical area, and the age group, and the organism's antibiotic sensitivity pattern. Usually for children above 3 months, the common pathogens associated with community-acquired acute bacterial meningitis are Streptococcus pneumoniae, H influenza, and Neisseria meningitis. Actually, 20 years back, influenza was the topper, but now after introducing hip vaccination in the universal immunization program, now the pneumococcus is the topper now. And what happens, the pneumococcus nowadays has developed resistance against penicillin and cephalosporin. Hence, vancomycin must be added to ceftriaxone and cefotaxime for initial empirical therapy for this child.
Yes. So ceftriaxone and vancomycin should be your empiric antibiotic of choice. And whenever you are ordering this antibiotic, please don't forget to give a loading dose. So loading dose, what is the advantage of loading doses? It helps to achieve the drug level above the MIC very quickly. Otherwise, if you start with ceftriaxone, usually we calculate 100 milligram per kg per day in 2 divided doses. So it may take 3 or 4 doses to achieve the drug level above the MIC. On the other hand, if you give a loading dose, that is stat 100 mg per kg, then the drug level will be quickly above the MIC. So you are attaining the therapeutic efficacy. Similarly, vancomycin also. So you give 30 mg per kg per dose start. So ceftriaxone and vancomycin you start with. Then based on your investigations and further culture reports, then we can de-escalate if needed. So these are the CSF analysis. So significant pleocytosis with neutrophilic predominant and low sugar, high protein. And we have both the blood and CSF group pneumococcus. That is a serotype 19F. So this is our original culture report. So look at this. If we have started only with ceftriaxone, ceftriaxone is resistant. So here nowadays around 40 to 50% of our isolates are ceftriaxone resistant. So we should empirically start on ceftriaxone and vancomycin if there is a suspicion of bacterial meningitis due to pneumococcus. So this is a landmark paper which came in 2016, and they have analyzed the isolates from 2008 to 2016, and they came up. So you see the penicillin resistance, it is to the tune of 40%. And similarly, the cefotaxime or ceftriaxone resistance is to the tune of 30%. So if you start ceftriaxone alone, then we may be wrong. And this is a serious disease with a significant end organ damage. So we are not afford to miss it. So we have to start with ceftriaxone and vancomycin empirically. And suppose if you find ceftriaxone sensitive, then we can stop vancomycin and continue only with ceftriaxone. There's a case 4, 3-year-old child, fever of 4 days duration, occasional cough, no fast breathing, no distress. There is no other focus also. System examination totally normal. But to a surprise, since the fever was more than 4 days, somebody is ordering a new CBC. Total count of 25,200 with polymorph predominant, hemoglobin is 10.2, platelets 2.1 lakh, very high CRP. CRP is 270. So what is the likely diagnosis here, Dr. Rajkumar? Hello?
pneumonia, ma'am. Most probably, child might be having a pneumonia or underlying bacteremia or even meningitis caused by capsulated organisms like Hib and pneumococcus. Sometimes it could be even pyelonephritis by gram-negative organisms and or hidden abscess or osteomyelitis caused by staphylococcus, or sometimes non-infectious causes like MIS-C, KD, and Sogia. They may systemic onset JA may give a picture like this. Because since a child is having extreme leukocytosis and a high CRP level, we have to look for make a diagnosis like this, ma'am.
So even if there is no respiratory distress, we are ordering a chest X-ray because the infant has extreme leukocytosis. That
Extreme
is the count more than 25,000 count.
More than 25,000.
Yes, sir. So always look for pneumonia, UTI, bone and joint infection if you have a high count, that is an extreme leukocytosis of more than 25,000. Thank you, sir.
Okay.
So what is the role of CBC in differentiating viral and bacterial? With only CBC, can you clearly able to differentiate viral and bacterial?
No, ma'am. Actually, CBC alone cannot guide us, ma'am, in making a decision in our day-to-day practice because it
So
lacks
except in
adequate
extreme
sensitivity.
leukocytosis, other than
Extreme
that, it is
leukocytosis.
very difficult. Okay,
Very
so it
difficult,
does
ma'am.
not
Less than
have an
25,000,
adequate
we cannot
sensitivity.
make a clear-cut decision, ma'am, on
Yes,
CBC alone. But CBC, if CBC and ANC, if they are used along with CRP, then we can make a clear-cut diagnosis of serious
So,
bacterial infections in
again,
infants and young
CRP,
children, ma'am.
utility of CRP in pediatric practice. Again,
Yes,
it
ma'am.
has a limited utility. Single value doesn't have so much
Doesn't have a,
significance.
yes, ma'am, because single value is neither sensitive nor specific
Not
enough to
specific.
identify. But if there are conditions where we can use CRP in a clear-cut way, ma'am. Very high CRP, especially more than 100 milligram per liter, will suggest the presence of a serious bacterial infection in such young children, ma'am. But still, now MIS-C and Sogia, they can also have more than 100 milligram per liter. But if we take serial CRP value, if you take serial CRP values rather than looking at a single value, then it will give a better picture, ma'am. Like if we see a serial value which is increasing or fails to decrease, that indicates either it's a treatment failure or development of complication like pneumonia, developing a pyothorax, or a non-infectious etiology like inflammatory, ma'am. And in neonatal sepsis also, serial CRP values would be very, very useful because 2 CRP at a 24 hours interval, if they are showing less than 10 milligram per liter, then almost it excludes sepsis. And finally, ma'am, actually, depending on CBC and CRP to make a clinical diagnosis is really risky. The good old SOAP format, subjective, objective assessment, and making a plan.
There is no substitute history, good clinical examination and assessment. Excellent. And single value does not have a sensitivity and specificity. Serial CRP may be used in follow-up, whether we are going in the right direction or the child is responding or the child is developing any complication. For that, serial CRP can be used in some scenarios. And if you're not able to find a focus with high CRP, definitely you are dealing with some undrained abscess or anywhere we are missing some pyogenic complication. Newborn sepsis also, as you rightly told, 2 CRP done at 24 hours apart may be used in excluding sepsis. Okay, sir. Thank you so much, sir.
Thank you.
Now we go to subacute fever. So, Dr. Somasundaram, sir, you please take over the question. So here there's a 10-year-old boy presented with fever of 8 days duration. Only complaint was occasional vomiting. On examination, you find there is a moderate hepatosplenomegaly. So what is the diagnosis? So since the child had 8 days fever, outside basic blood counts were done. Total count of 4,300, polymorph 71%, lymphocyte 23, monocyte 6, hemoglobin is okay, platelets low normal 1.2 lakhs, urine routine normal with elevated SGOT-PT. Rest of the investigations like RFT and other things are normal. So how will you approach this child?
Yeah, thank you. Before that, my sincere thanks to the office bearers, Dr. Jarani, Madam, Dr. Narmada, and Professor Rajkumar for opportunity to participate in the CME. And thank you, Dana, for your excellent real-life questions and also organizing the PPT. And even though my batting field is developmental pediatrics, I will try to bat the balls you are being bowled on me. So thanks. Coming to the case scenario, so it's a 10-year-old boy with more than a week fever, that is a 8 days fever with the organomegaly. And the first things which we have done, the first set of things which we have done show a leukopenia with an polymorph predominant and a low platelets, and then SGOT and SGPT, which is elevated. So a transaminitis is there, a thrombocytopenia is there with an increased polymorphs. So this picture will be a bacterial infection. So this picture will mostly point towards a bacterial infection, and with the low total count, I will suspect an endemic fever. And another point to be noted is the eosinophil count. The eosinophil count is 0 in this case. And many studies have come out that eosinopenia, that is the 0 eosinophil count, is an indicator of a possible enteric fever. So I will vote first as an enteric fever as the first possibility in this case.
Will you think of scrub typhus in this child, sir?
Yeah, I will also think about scrub typhus in this child.
What is slightly unusual is there
It's
is no
the
leukocyte.
leukopenia. Leukopenia
So
is the
usually
first.
by second week, if it is a scrub typhus, there will be leukocytosis, and by the time there will be third spacing, and
Correct.
there may or may not be SR. So here,
Yes.
most likely our diagnosis is probable enteric fever. So
Correct.
enteric fever, there are battery of investigations available. Which
Correct.
one you want to choose? Blood culture, typhoid, IgM, Vidal? No, I want to have 100% sensitivity, so I'm going to order for both, all of the above. Which one you want to order?
Depending upon the week, since this boy has presented on the 9th day, I will always think about an antibody as the first choice. But in addition to that, I will always order a blood culture also because blood culture, the sensitivity and the sensitivity is more, and the pickup rate is also more. So I will always order an antibody. So the three things are very important. One is the lab parameters, the second is the blood culture, and the third is the antibody. So as you all know, the blood culture will be more, pickup rate will be more in the first week. The second week and the third week, the blood culture. So this is the slide. The positivity comes down 90%, 75%, 60% in the third week. And after the pyrexia settles down, it is only 25%. So if you want to get the maximum levels, always send the blood culture in the first week. So we have known the mnemonic in the undergraduate days, that is BASU. So B is the first week, antibody in the second week, stool culture in the third, and urine examination in the fourth, urine culture in the fourth. But we are not at all doing stool and urine culture nowadays. But we are still sticking on to the blood culture in the first week and antibodies in the second week.
Usually antibody tests are slightly
Blood culture may be, so the blood culture even then can be a false negative things in certain scenarios, because the volume of bacteria will be low. That is one situation. There are many situations in amateur fellow lab technicians mixing the broth and the blood. The dilution should be in the 1:5 ratio. If they have collected only minimal blood and the dilution is not in the 1:5 ratio, the blood culture can come as a negative value. And if the prior antibiotic therapy has been started and then the blood culture has been sent also, there is a chances that even though it is a possible enteric fever, the blood culture may turn negative. So always have an eye on the other investigations, also the supportive things when you are suspecting clinically a typhoid fever.
Usually typhoid fever, if it's a good lab, we will be able to get 80 to 90% of the sensitivity, even if the child has received 1 or 2 doses of antibiotic. So always send a blood culture if you suspect a strong possibility of typhoid fever. And these serological tests are slightly, the sensitivity and specificity is not very good. And we have to correlate with the clinical status of the child. So with regard to S-typhoid, IgM, any antibody test, so IgM, IgG, they are antibodies. It should start rising after 5 days only. So you should order only after 5 days. S-typhoid, IgM, Vidal should be done only after 10 days of illness.
Vidal, yes. So Vidal, as you have mentioned, it should be done after 5 days. There are labs even when we write only the basic counts and Deggy test on the 3rd day, there are people who wanted to, they themselves will tell the lab, or do a Vidal also for me. So
since we are in an endemic country, we should not be ordering Vidal and S-typhoid IgM for all the patients with enteric fever. It is always gold standard is blood culture, blood culture, blood culture. Correct. Still, you are not confident and the fever is still persisting. We don't have the diagnosis. Then we always go for bone marrow culture to establish a diagnosis. Correct. So what is your empiric test? We made a clinical diagnosis of probable enteric fever. So what is your empiric choice of antibiotic here? Ceftriaxone, ofloxacin?
So the empiric choice will depend upon whether the child is a stable child, whether the child is not sick looking, whether the child is able to take a oral antibiotic or not, whether the child is dehydrated or in shock, or it's a complicated case or not. If it is a stable child able to take proper food and the child can take orally, the first choice will be, and I don't know, there are certain clinicians who say cefixime as the first choice, and there are certain clinicians who say azithromycin as the first choice. So you will be able to guide me whether to finally settle on the things. But the cefixime, the very, very important thing you should note is it should be 20 milligram per kilogram per day, because Salmonella is an intracellular organism, and your 8 to 10 mg per kg used in other infections like UTI will not be able to kill this intracellular organism. But the upper limit is always 1 kg, 1 gram. Don't, if you are treating a 50 kg adolescent boy, don't put 2.5 grams, 2.5 grams BD for the child, because the upper limit is always only 1 gram in this child. So cefixime 20 milligrams per kg per day in 2 divided doses for 14 days with an upper limit of 1 gram. That is the oral drug. The second possibility, or it can be the first possibility as per few studies also, is azithromycin, because that has got a high intracellular penetration. That also the same dosage, that is 20 milligram per kilogram per day as a single dose also. The regular dosage we use is 10 milligrams. So here it is 20 milligram. Here also the upper limit is only 1 gram. So don't treat with the 60 gram boy with the 1.2 grams of azithromycin. The main advantage of azithromycin is 7 days duration. So 7 days of therapy is sufficient for azithromycin, because it's 1 day. Once these are the advantages of azithromycin. Shorter duration of treatment, that is 7 days. Once daily administration, cost effective. The patient will save a lot of money in buying the tablets. Low incidence of side effects, less relapses in comparison with ceftriaxone. The relapse rate in azithromycin is only 0.3% as per the records. High intracellular concentration, 500 to 50 to 100 times that in the serum. So this is if a child is able to tolerate a oral drug and the child is not dehydrated and in shock or without any abdominal complication. If the child is a complicated enteric fever, the drug of choice is always ceftriaxone. It is 75 to 100 milligram per kg per day. Here also there is a point. The upper limit should be 4 kg. So, 4 grams. So if you are treating a 50 kg boy or an adolescent boy, don't give 2.5 grams per 2.45 grams BD. It is always the upper limit is 2 grams BD. The other thing which we can do, if there is lot of biliary sludging and hepatitis or transaminitis, we can always think about cefatoxime as the alternative drug. Cefatoxime, it is double this dosage. Instead of 75 to 100, you can always go for 150 to 200. And the upper limit is also, instead of 4 grams, you can go up to 8 grams. So this is in a complicated child with the UTI. So you should always get the defervescence in 7 days after starting the therapy. If there is no defervescence after starting the therapy, you have to think about abscess formation or the child going in for HLH, or if there is a co-infection or something like that.
As you rightly pointed out, if there is an uncomplicated enteric fever, not much of vomiting, child is able to tolerate only, there are two options, cefixime or azithromycin. Complicated enteric fever, you are going to hospitalize and going to start on ceftriaxone. After ceftriaxone, then suppose if you get the defervescence in 4 to 5 days, then what will be the discharge antibiotic? It can be either cefixime or it can be azithromycin. So currently we are using the policy of we'll start with ceftriaxone and we are switching to azithromycin. And what we observe is there is a very, very less relapse in using azithromycin. That is our observation. The main disadvantage with cefixime is 14 days. No parents or the compliance is going to be very less. That is the main disadvantage with cefixime. Otherwise, we should use a proper dose. You rightly pointed out the maximum dose is even up to 1.2 grams. They say we can go up to 1.2 gram, and azithromycin maximum of 1 gram per day. So these are the advantages. So as a OP, if the child is stable, we always start with azithromycin, and the duration is only 7 days. So compliance is going to be good. So is there a role of dual drugs in the management of enteric fever?
No role of dual drugs. There are still companies coming up with the irrational antibiotic combination saying double therapy for typhoid.
There is no evidence for that.
Turn that page. Now. No, you should not treat.
And one more thing is quinolone resistance is very, very high. Again, don't use empirically quinolone, ofloxacin or ceftofloxacin. So now the role of quinolones is going away. For UT also we are not using. For enteric fever also we are not using. So we are not using quinolones regularly in pediatric practice. So when will you suspect relapse and how to manage it?
Any patient who has the same features of typhoid fever after 30 days with the culture positivity, we will it as a relapse. And the relapse, the drug can be used. We need not find out which is the higher drug, above ceftriaxone or something. Can we put on some other which has a more efficient concentration or something like.
So whatever we have used, we can use the same drug.
The same drug for the same duration that will treat relapse.
Yeah, excellent. So we'll move on to the next case. Here it's a 2-year-old boy, fever of 9 days duration, presented with fast breathing for 4 days, sick, toxic, with moderate respiratory distress with bilateral diminished air entry. On examination, you have moderate hepatosplenomegaly again. This child was hospitalized outside and received meropenem and vancomycin. The investigations, it was total count of 18,400 with polymorph predominant, hemoglobin 10.1, platelets 80,000. CRP of 96 with elevated SGOTPT, chest X-ray, bilateral pleural effusion. So what is your thought process on this?
Yeah, so the difference from the previous case is here it is a leukocytosis directly,
Yes.
a bilateral pleural effusion. That is because of probably the hypoalbuminemia which has set in. So considering these two things, I will again suspect a tropical infection again in this case. If this was the probable means diagnosis which has been given, I will vote for a scrub typhus because CRP is higher, so it is not a viral illness and not likely to be tuberculosis with this short duration and these things. So I'll also think about a scrub typhus as the
Even though there is a
possibility.
pleural effusion, there are multi-system involvement. There is hepatosplenomegaly and other things are happening. So we will not think of tuberculosis here. So enteric fever, we previously discussed, there is no need for third spacing and counts will not go high in enteric fever. Usually counts will be normal, or by the end of second week, in fact, we can get pancytopenia. Pancytopenia is reported in 20% of cases of enteric fever. So this is a high count. So chance of this being enteric fever is very, very less. So we are left with two possibilities, whether scrub typhus or some other unknown viral illnesses. But yes, CRP is also, it's on the higher side. And with elevated SGOTPT third spacing, we consider scrub typhus as our initial diagnosis. So what about the thrombocytopenia?
Right. So thrombocytopenia here in scrub typhus is because of platelet aggregation as such. So it is an accentuated immunological reaction and those things. So the platelet gets aggregated as shown in the figure. So this is the reason for the pseudo thrombocytopenia which occurs in this condition rather than a different etiology for thrombocytopenia in dengue and those.
The platelets are in clumps. If you call the lab, you discuss with them, then they say the counter value is only 80,000, but manually count it comes to more than that. So this is pseudo thrombocytopenia. So this is a paper from Chennai, Dr. Sarla Madam, Ail Madam, they have recently published. And so the platelet aggregation is seen in other conditions also like hepatitis A, EBV, scrub typhus, and it's an immunological reaction. And they concluded the presence of platelet aggregates in a peripheral smear is a diagnostic test for scrub typhus and febrile children with thrombocytopenia by automated count. If you manually check, it will be more than that. So this is the importance of pseudo thrombocytopenia.
Sure.
So this is an SR. So should we have SR in all the children with suspected scrub typhus?
No, we can't expect that, madam.
In fact, this child has multiple SR here, 4 SR.
So it is always in the intertriginous
Nearly
areas.
only in 40 to 60% only they have reported SR. Even if there is no SR, we have to strongly suspect scrub typhus. And nowadays, scrub again, it has become an endemic in our part of And in fact, for children with like meningitis kind of presentation with altered sensorium with minimal third spacing, hepatosplenomegaly, thrombocytopenia, we should consider scrub typhus even if there is a CNS involvement. We are seeing quite a number of children with CNS involvement also. Even if there is a CNS involvement, doxycycline is more than enough. It's a very good drug.
So I'll finish the dosage of doxycycline, madam.
Yes, sir.
Yeah, so the cornerstone of treatment is doxycycline, and whatever may be the system involvement, it is always doxycycline as told by Dr. Dhanlakshmi. So if the child is less than 40 kilogram, the doxycycline dosage is 2.2 milligrams per dose, or it is 4.4 grams per day in divided doses for 7 days.
2.4 milligram per kg per day.
Milligrams per kg per day. And if the child is more than 40 kilogram, the doxy, the full tablet, that is the 100 milligram tablet can be given because it is 2.2 works out into for more than 45 or something like it is 100. So you can give the whole 100 milligrams tablet twice a day for 7 days. The duration is 7 days.
Yeah.
can't give
Whether
azithromycin.
doxycycline can be used or not, but studies have clearly shown that if you are using for a short duration, now we are going to use it for only 7 days and it doesn't have any risk. So whatever the age, even in newborn, we have used doxycycline safely. You should not worry about the age group. So age group, we always use a higher dose, 4.4 to 6 milligram per kg per day. Maximum is 100 milligram BD. That is the dose. So next case, 2-year-old child previously well, had a fall while playing and was seen in the OPD with a history of 2 days of fever and limp. On examination, the child is not able to bear weight on the right leg, but there is no obvious external swelling. So you order whether you want to know whether it is some fracture kind of thing or whether it is a true infection. We are ordering a blood investigation. Total count is 15,400 with polymorph predominant. Hemoglobin is 10.2, platelets 3 lakhs with very high CRP. CRP is 292. So how will you approach? So what will be your differential?
So
whether it is a septic arthritis right hip or it's just a reactive arthritis or it's a fracture femur or some unrelated to the fall and pain. It is a viral illness with myalgia.
Yeah. So sometimes parents will try to deviate our attention, or probably they will a different issue which has happened, because they will always say attribute to this is a fall and the child has attained the injury and this pain and the limping is because of this injury, and the fever is because and the fall nala bayandita and the the fever vandrichi and all they will try to say. So we should not be misguided that this is just an this is a fracture femur or something like, or it is an myalgia which is causing this problem or something like. We should always examine the child properly and then try to find out whether this is an fracture or it is a different issue which has made the child fall or something like. So with this scenario of increased CRP and total counts are elevated, I will always think about a septic arthritis of the hip, because that only will cause a marked CRP elevation with an increased total count. So
whenever we are encountering the scenario like this, whether it is a fracture or septic arthritis, always preferable to do a CBC CRP. Here CRP
correct.
Makes a difference. If it is a very high CRP, then it points us towards an infective etiology rather than fracture.
Right.
So what will be, so now your probable diagnosis is septic arthritis right here. So what will be your empiric choice? It is ceftriaxone Clinda or no, I want to cover all the organism under the sun. I will give meropenem vancomycin or amoxiclav or clindamycin. What will be your choice?
We should always add clindamycin in this case, and also a broad spectrum, and also the ceftriaxone can be the additive thing. We have
already discussed before choosing the empiric choice what are the organisms which is going to cause this syndrome. So it is mostly a staphylococcus or it is a streptococcus. Rarely in children less than 5 years of age, they say Kingella kingae is also to be considered. So ceftriaxone will cover Kingella kingae, staphylococcus, staph in the sense it is MSSA or it is streptococcus. So clindamycin for MRSA. So empirically we start with ceftriaxone Clinda, and then based on the further test, then we can modify. So here, since it is a
this will prove the diagnosis that the clinician has attempted to do an orthotomy also. Yeah. So we have drained the pus from the hip joint, and the pus culture and the blood culture has shown gram-stain, gram-positive cocci in clusters, that is methicillin sensitive staphylococci in the pus culture also, which is sensitive to clindamycin, sensitive to cloxacillin also.
So is sensitive to methicillin, so that is called MSSA.
Solid also.
We have Clinda sensitivity also. So now what is your plan? Whether you are continuing with clindamycin or you want to change to some other antibiotic?
No, I will prefer cloxacillin as the, because we have now confirmed that it is an MSSA. Yeah. For MSSA, the drug of choice or the drug which I will prefer will be an oral cloxacillin, which can be continued for weeks together.
But unfortunately, oral clox is not available. So IV cloxacillin or cefazolin we can give. And once we want to switch to oral, then we can switch to cephalexin. So for MSSA, if you want a bactericidal action, then it is first generation cephalosporin, that is cephalexin or cefazolin or cloxacillin. These are the ideal drugs for MSSA. Even if Clinda is sensitive, it is an inferior option. Similarly, vancomycin. For vancomycin, if you are using vancomycin, and if you know if it is MSSA, then vancomycin is a much inferior option. We should not be using vancomycin for MSSA. So if you carefully look at the sensitivity, if you want to use clindamycin, then again we need to look into the sensitivity for erythromycin. So there is a test called D test. Even if it is a clindamycin sensitive, if there is a discordance between these two drugs. Then once you start with clindamycin, in vitro, there may be inducible clindamycin resistance. So D-test you have to order. Based on the D-test results only, we can say whether we can use clindamycin or not. So safely, you can use cefazolin, cephalexin, or cloxacillin. If you are not able to get any of the drug, then amoxiclav also, it is a good drug for MSSA. Linezolid should not be using. It's a broad spectrum and it is a reserved drug.
Yes.
So many resistant organisms like MRSA and VRE, vancomycin resistant Enterobacteriaceae, and even for MDR TB, it is a drug. So we should preserve linezolid. So for simple infections, we should not be using linezolid. So this is one more child. So Master X, 3.5-year-old boy, developmentally normal. So he had a documented neutropenia at 2 years of age, but he lost for follow-up. Now he came back after 1.5 years. He presented to us with intermittent high-grade fever for 9 days duration, progressively palpable skin lesions for 5 days, bilateral lower limb swelling for 1 day. So on examination, is febrile, toxic, bullous lesions over both the lower limbs. He is tachypnic. These are the bullous skin lesions. He is in hypotensive shock. So he is tachycardic, feeble peripheral pulses, BP is less than 5th centile. So how will you approach this child? So this child has a documented neutropenia previously, and he presented now with a septic shock. So how will you approach this child?
So this child has gotten the area of infection is the skin and soft tissue infection. So that is the area of this infection. So considering these things, we can always think about and evolve cellulitis, which has evolved into an necrotizing fasciitis, because the color of the skin shows that there has been some necrotizing tissue also. So necrotizing tissue fasciitis can be one diagnosis, because it has started as an cellulitis and it has evolved as a major infection within a short duration, because the child had got neutropenia at 2 years, which can be a persistent one, and that has caused and initiated the spread of infection in the rapid way. So that can be the possibility.
Neutropenia with septic shock, we want to cover all the organism. Even
correct.
It is a skin and soft tissue, which is commonly caused by Staphylococcus and Streptococcus. We want to cover the other rare organism also, including correct. The gram-negative organism like Pseudomonas and
anaerobes and those things also. Because necrotizing fasciitis is always polymicrobial. Yes. So until otherwise you prove the organism what is that, we should always do the polymicrobial coverage. Yeah. So of choice will be the clindamycin, the meropenem, and the vancomycin, which has got the coverage to all the organisms which has been the polymicrobial.
So for antitoxin effect and anaerobic effect, and here meropenem for the gram-negative coverage for E. coli, Klebsiella, Pseudomonas, and vancomycin for MRSA. So we are starting with mero, vanco, and clindamycin. So these are the labs. See, look at the labs. Here the total count is again low. 1,700, again persisting neutropenia, again hypotension. So this fits in with the criteria for probable toxic shock syndrome. So INR is deranged 1.82 with elevated urea, creat, renal impairment, and coagulopathy. So further course, we are starting on meropenem, vancomycin, clindamycin. So blood culture has grown, Pseudomonas. Fortunately, we have started with meropenem, which is going to be sensitive. So since this child has a neutropenia, very severe presentation. So any other workup needed for this child, sir?
Yeah, so it was a well-thriving child till date, and sudden onset and rapid progression of the disease. So I should always, with the note of 2 years neutropenia, I will always think about some immunodeficiency in this child. So these are these pointers towards a primary immunodeficiency. So yes, spur is the mnemonic for that. A serious infection, a persistent infection for a longer time in the same area, or an unusual organism causing
unusual
site, or a recurrent infection of the same site, or if the same infection runs in families, I will suspect a primary immunodeficiency also.
Okay. So this is a
secondary immunodeficiency, that is HIV.
Yeah. So this is a serious infection caused septic shock, and unusual skin and soft tissue usually by Pseudomonas is very rare. So here we have 2 pointers for further need for immunodeficiency workup. So we are ordering an immunoglobulin profile, and all were low. So IgG, IgM is low. How you proceed further?
Correct. So we are thinking about, and neutropenia was there. So we are thinking about an lymphocyte issue. So the lymphocyte can be a B cell issue or a T cell issue. So we should be able to find out what is the lymphocyte which is lacking by a flow cytometry, whether it is a B cell or a T cell. And also we should also rule out complement deficiency and immunoglobulin deficiency. Here, this immunoglobulin profile shows that all the immunoglobulins are reduced. IgG is reduced, A is reduced, M is reduced, and E is reduced. So it is a combined thing where all the immunoglobulins are. So it's an A gamma globinemia. And also this flow cytometry shows that the CD19 B lymphocytes are totally absent. So the immunoglobulin producing B lymphocytes are absent. So it is only a immunoglobulin deficiency. B cell is a dependent immunoglobulin deficiency.
Excellent. A gamma globulinemia we have proved by flow cytometry. So we gave antibiotic as per sensitivity.
Correct.
For the skin lesion, split skin graft was done, and
IVAG will be started.
IVAG monthly replacement and cotrimoxazole. So always you remember the mnemonics per. So serious infection, persistent infection, unusual site, recurrent infection, and runs in the family. Recurrent infection, always recurrent pneumonia. We always come across recurrent pneumonia, and most of the time it's turned out to be CGD. So, and if you suspect immunodeficiency, preliminary screening test should include immunoglobulin profile, NBT, HIV. These are the basic tests. And if it is a very young child, for example, if it is less than 2 months, 3 months old, then you take an X-ray to look at the thymus. And always have the habit of looking ANC and ANC, especially in children 1 to 2 years, till 2 years of age. So most of the time we'll diagnose kid that is severe combined immunodeficiency. But retrospectively, if you go back, most of the children will have lymphopenia. So it's a classical clue for severe combined immunodeficiency. So don't forget to see the differential count ANC and ALC, and strongly suspect immunodeficiency if you have qualifying markers for SPUR. Thank you, sir. Thank you so much.
Thank you.
Now we go to chronic fever. So it's an 8-year-old boy from Andhra. He presented to us with fever of 16 days duration. There is a minimal pain and swelling in the right knee joint. There is no history of weight loss or loss of appetite. For the 16 days fever, he received multiple antibiotics. On examination, you find there is a mild pallor. There is no lymphadenopathy. There is a moderate hepatosplenomegaly. So investigation, since there is 16 days fever, there are a battery of tests done, and total count is again 4,300, volume of 64%, hemoglobin is slightly low, 9.6, and platelets are 90,000. Mildly elevated SGOT-PT with low serum albumin. Rest is normal. RFT, urine routine is normal. Dr. Ashwath, can you take up this slide?
Good evening, one and all. My thanks at the outset to the ID chapter for having me as a panelist, and also to Dr. Dhanalakshmi. All of us are getting some voice, but Madam has been going hammer and tongs, trying to collate all the evidence and trying to present data in a very neat manner. Thanks once again to Dhanalakshmi ma'am for being a good shepherd. Now, coming to this case scenario, this is a boy from Telugu Desam with a fever of 2 weeks duration. So far we have been discussing only acute fevers. Here we have a child with 16 days of fever with pallor, hepatosplenomegaly, and the only objective finding other than that is a swelling in the right knee. On examination, the screening investigations are showing a mild leukopenia and reduction in all the 3 counts with a mildly deranged liver functions. So my differentials for this child would be, as always, infections first, second to think of reactive arthritis, and third possibility is, because of the pancytopenia, the possibility of an inflammatory condition or hematoreticular malignancy, because ALL is very, very prone to present with articular symptoms, not arthritis, but arthralgia. So those would be my broad differentials, ma'am. Infection first, reactive, immune, malignancy.
If it is an infection, what infection you consider?
Pallor, hepatosplenomegaly, prolonged fever with osteoarticular manifestation. I think my first differential would be leptospirosis, or brucellosis. More brucellosis.
Leptospirosis is an organism. It responds to whatever antibiotic you give. This child received multiple antibiotics, and leptospirosis is not on the cards. So this is going on for nearly 16 days. So some chronic bacterial infections like brucellosis, myelitis should be our differential diagnosis. So how to establish a diagnosis?
So the basic investigations have been done. So the next would be to go for a gold standard test.
Brucellosis
have been done. So the next time, if my differential is brucellosis, I would like to go for an agglutination test, serological test, because at this point of time, doing a bacterial isolation will be very difficult. and it'll be very difficult to get brucella. I would like to go and revisit the history and find out where this child's background is, whether there is a history of drinking unpasteurized milk or whether the child has been playing in the farm with farm animals. That history would be supportive. 16 days down the illness, I think definitely a serological investigation would be my first investigation choice.
History of unpasteurized milk intake and history of animal contact is more important. And here the counts are borderline. Usually in brucellosis, the counts will be like this only. It never goes up like in enteric fever. It will be hovers around 4,000 to 5,000 only. So we are ordering whatever it is, we have to order a blood culture also. And the serology, again, if we are not able to prove anything, then we go for serology. And one more thing, if you're strongly suspecting brucellosis, we have to inform the lab. It may grow after 5 to 6 days also. Sometimes we discharge the patient. It's a chronic fever syndrome. So sometimes we even 1 or 2 cases we have discharged the child and we got a call from the lab like brucella is growing. So we have to always inform the lab like we are suspecting brucella, don't discard. So the next investigation probably we should go for is a confirmatory diagnosis is a bone marrow culture also we can do. So that's how we establish a diagnosis of brucellosis. So FUO. So what is FUO? It is a fever of more than 14 days. That after a careful history taking, physical examination and basic laboratory investigation. So what are the clues you get, what you want to get from the children with FUO, sir?
So same thing, ma'am. So first of all, we have to make sure that whether there is a documented fever. So many of the times, pyrexia of unknown origin may not be pyrexia at all. Second is, it may not be unknown pyrexia. It may be known pyrexia. Only thing we are not diligent enough in looking for the proper history or doing the relevant physical examination. Like the picture showed, eschar on the external genital is very, very easy to miss in a busy OP practice unless we disrobe the child, take the child into confidence and do a thorough examination. So I think history and geography is more important. Where does the child come from, rural or urban? Has there been exposure to monsoon? Has there been rainwater collecting near their house? What is the child's life history, farm animal contact, pet animal contact? Those are the points I think which would be very important in helping.
How's the travel history, contact history, animal contact and medication history, immunization, anything the child has recently taken, family history. Suppose the adolescent girl, unexplained fever, then somebody in the family is TB positive, you work up for TB and cardiac valvular disorder. Then you think of infective endocarditis, and don't forget to examine the fundus, oropharynx, temporal artery, especially this is for adults, and abdomen, lymph node examination, spleen, joints, other system examination is a must. Management with if you are not able to make a definite diagnosis and the child is stable, you can avoid empiric drug treatment. There is no point in starting multiple drugs without knowing what it is. So observation, outpatient temperature chart, as he rightly pointed out, temperature, whether there is a documented fever or not, it is very, very, very important. So in India, notably infections, TB is more common. So most of the time, especially in adolescent age group, we are seeing a lot of pulmonary or extrapulmonary tuberculosis. And apart from infections, non-infective etiology like collagen vascular disorders and neoplasms should be considered in the differential diagnosis. So this is how we approach patients not truly having fever, not fever of unknown origin. So if you ask them to monitor temperature, child will be absolutely well. And if you ask them to monitor temperature, there won't be no more than 99. So this is not a fever at all, or it may be an unusual presentation of a common disease. Sometimes enteric fever we often see. So it's slightly prolonged fever. So, the doses may not be sufficient in a non-toxic trial. So it can be an unusual presentation of a common disease, or it can be a common presentation of an unusual disease. For example, this child had a septic arthritis. It's a little unusual infection, but presented with arthritis. So this can be the diagnosis. So always infections, apart from infections, you think of inflammatory conditions, neoplasms, miscellaneous. So like SLE, SOJ, these are all should be your differential diagnosis. So next case, 13-year-old adolescent girl, previously well. So she has a weight loss of 5 kg in the last 6 months, and she had a rashes in the face on and off for the past 2 months, fever on and off for 1 month, no history of contact with TB, no obvious pallor or bleeding manifestation. So these are the investigations. Total count, there is a definite leukopenia. The total count is 3,800 and hemoglobin is 9.8, platelets no normal 1.2 lakhs with very high ESR 120, CRP is negative. Urine routine showing proteinuria. RFT is normal. LFT, there is a low normal serum albumin, rest is normal. So how will you manage this child, sir? What is your differential diagnosis first?
So again, this 13-year-old girl, the fact that she's an adolescent girl and she's been having a chronic illness, documented fever with rash, and the counts are showing reduction in all the 3 formed counts with a high ESR. And also there is a proteinuria. Definitely infection would go down the list, and probably a vasculitis, systemic vasculitis will be my first differential diagnosis. And also the surprising disparity between the ESR and CRP. ESR is very high, but the CRP is negative. That is also a very, very well-known phenomenon in vasculitic disorder, especially SLE, ma'am. So definitely SLE should be considered in this child.
So there is a nearly pancytopenia. So leukopenia, hemoglobin is on the low, normal platelets are low, and this characteristic of SLE. So CRP, ESR discordance is characteristic. And again, you have one more evidence. There is a renal involvement in the form of proteinuria. So our first differential diagnosis here is SLE. So infections are less on the cards because here rashes usually will not happen in infections, and here this type of clinical blood counts will not happen in infections. So this is more likely a vasculitis like SLE. And malignancy also less on the cards because rashes are unusual. CRP-ESR discordance will not come in malignancy. So this is less likely. Anyway, we need to do a bone marrow before we start on some immunosuppressants. So we will do bone marrow also. So this is how, so this always look at the urine examination and this ESR CRP discordance and adolescent girl especially. Then you think of vasculitis as our first differential diagnosis. So this is a last case, 3-month-old infant is first born to non-consanguineous parents, still now thriving well, received vaccination till 10 weeks. So he presented to us with fever of 12 days duration. Initially it was low grade, now high grade for the past 6 days. There was cough and mild tachypnea for the past 1 week. Is not feeding well. And the child was received amoxiclav for the past 4 days. On examination, there is a mild tachypnea with lower intercostal subcostal retractions. There's hypoxia, saturation is only 88% in room air, and you hear a bronchial breathing on the left side. Other systems are within normal limits. So this is your chest X-ray. So there is a definite consolidation on the left side. How to approach? What is your empiric choice?
Ma'am, this is a well-thriving infant who has got incomplete vaccination status, and he has come with features consistent with a lower respiratory tract infection, not a respiratory failure, and having failed a fairly good antibiotic. The child has already received 4 days of amoxicillin clavulanic acid. I assume the dose was right. The chest X-ray is consistent with a left upper lobe pneumonia. So considering this age of infancy and a partially immunized child not responding to first-line antibiotics, definitely Streptococcus pneumoniae, H. influenzae. In addition to that, I will also keep Staphylococcus aureus as one of the differentials, ma'am. So between the choice of A, B, C, and D, considering the clinical child community-acquired pneumonia, I think I would go with choice number 2. Yeah. Ceftriaxone, clindamycin. Clindamycin to cover Staphylococcus and ceftriaxone to cover strep pneumo and H. influenzae.
So we expect the clinical response in usually 48 to 72 hours. This child has already received good antibiotic, which is going to cover your routine community-acquired pathogens like MSSA will be covered, and Haemophilus will be covered, and Streptococcus will be, pneumococcus will be covered. So here MRSA is not covered. So after 4 days of amoxiclav, definitely we need to cover on MRSA also. So we are starting on ceftriaxone and clindamycin. So this child again receives ceftriaxone clinda for 72 hours, but there is no improvement. Fever spikes are persistent. Pulse is unfortunately not growing anything. So respiratory distress and hypoxia worsen. So now how to proceed? So we don't know what to do. So we are ordering a repeat X-ray.
So whenever a child does not follow an expected clinical course, we go back to the basics. Is our diagnosis right? This is community-acquired pneumonia. We are not in doubt there. Second is the drug appropriate? We have already changed one drug to another. We have added 2 drugs. We believe that we've got a good combination covering the most likely pathogens. So diagnosis is right, drug is right. Assuming that it's an inpatient care, we assume the dose is also right. And if the patient continues to show an inadequate response, we have to look for a complication like either an abscess formation or a nematocele formation, or the child has got a pneumonic effusion or an empyema. Or it is possible that we are treating the wrong organism. So these are the thoughts.
We did a repeat investigation. Since the child is deteriorating, hypoxia worsening, we again escalated our antibiotics. So we escalated to meropenem and clindamycin, whatever worked, we added azithromycin also. Then so having started this broad spectrum coverage covering all the possible organisms which can cause community acquired pneumonia, what other investigation you would like to order, sir?
Again, because the child is not showing a good response and the child is only 3.5 months old, I like to see the BCG scar. As previously discussed, I would like to look at the lymphocyte subset analysis, and definitely tuberculosis has to be ruled out now that the child is worsening steadily despite appropriate care, ma'am. So I think we need to look for unusual organisms and also look at the host.
Yeah. So we also thought of immunodeficiency. The child is not responding to whatever appropriate antibiotic we are giving. So basic immunodeficiency workup in the form of immunoglobulin profile, T and B, lymphocyte subset analysis, NBT, HIV, but then everything was normal, nothing was conclusive. So we ordered for a chest X-ray, CT chest. So we ordered for a CT, which showed multiple necrotic lymph nodes and a cavity in the left upper lobe. And we did the RGJ, and it came resting gastric juice, AFB smear is positive, and gene expert MTB detected, and RIF resistance not detected, started on ETT. So the persistent fever in pneumonia. So what are the causes? As he rightly pointed out, it may be the improper choice of antibiotic or inadequate dose of antibiotic or dealing with the resistant organism or a wrong diagnosis. Sometimes there may be CPAM, which we are treating with multiple antibiotic. Then only we realize it is a congenital malformation of the lung. It is not pneumonia. So whether we are dealing with the right diagnosis, and always these should be the first. So complications like pleural effusion, empyema, if it sets in, whatever antibiotic you are going to give, unless you drain the pus, fever is not going to come down. So first rule out complications like pleural effusion, empyema, lung abscess, metastatic infections. Thank you, sir. Thank you. So few carry home messages. So in acute fever, in acute febrile illness, we need to educate the parents regarding warning signs and ask them to monitor temperature at home. Only paracetamol for fever, avoid drops, use single strength formulation only. So there are a lot of cases where there is no difference. Even among the educated parents, they think both the drops and the syrup both are same because both are available in suspension. So we should teach them which is drops, which is syrup. So always in our hospital, thanks to Dr. SBS, so we have stopped using drops at all. So we use only single strength formulation. Paracetamol 125 is the only strength available in the hospital. So we are not using other strength. So make it a habit to use only single strength formulation. Ibuprofen can be used as an antipyretic. Caution in dengue. Already liver is affected. So there is an increased chance of hepatotoxicity and causing gastritis in dengue. And judicious use of investigations like fever without focus. So always you order for a urine protein first, then based on that you carry the further investigations. Fever without focus, always consider UTA, especially in younger age group. Extreme leukocytosis, you consider UTA, pneumonia, meningitis, osteoarticular infections. Antibiotics are not antipyretics. So without having a probable diagnosis, don't start antibiotics. And this is actually traffic light system. This is followed in UK. This is a nice guideline how to segregate the children with fever. So they look at the color, activity of the child, respiratory rate. So tachypnea. So this is an amber color, red color. So amber color means the chance of having serious bacterial infection. There is an intermediate risk. If the child has symptoms consistent with the red, then the chance of serious bacterial infection is high. If you take respiratory, only tachypnea comes in the amber color, and if it is a grunting with severe respiratory distress, it comes to red. Circulation and hydration. So tachycardia, hypotensive shock. So here, other important things you have to remember is if the age is less than 3 months and temperature is more than 38, that is 100.4, then it is a red. So you have to look for serious bacterial infection if the child less than 3 months presents to you with documented fever. And other things are CNS symptoms like bulging fontanelle, neck stiffness and seizures and other things. 3 to 6 months, it is more than 39 degrees, then you should be very careful. So these are the traffic light system, how to triage the children with fever. So coming to fever of 1 week duration, in endemic area like ours, consider enteric fever. If fever persists for more than 5 days, blood culture is a gold standard. Don't rely on serology. It's neither sensitive nor specific. So consider scrub typhus. If there is hepatosplenomegaly, third spacing, with or without SR, there may be associated through pseudothrombocytopenia. Not all platelet count low, that is thrombocytopenia or dengue. Nowadays, we are seeing dengue with enteric, dengue with scrub typhus. So be careful if a child presents to you with scrub typhus. So look careful clinical examination. If there is a hepatosplenomegaly, then you look for associated co-infections. So fever is not a sign of ceftriaxone deficiency. In case of PUO, you have to take a meticulous history taking, serial clinical and focused investigation. It changes. Sometimes you get a new finding. So daily you have to concentrate on clinical examinations. Suddenly you may find a ulcer, oral ulcer. So sometimes we had picked up IBD also, so oral ulcers in the mouth, or they may develop erythema nodosum. So daily serial clinical and focused investigations are must. Don't forget to look at the fundus. Avoid empiric antibiotics if the child is stable. So at now, last, so when to suspect PID, remember the mnemonic spur. Serious infection, persistent, unusual infection, unusual organism, or an unusual site. Recurrent infection and which runs in the family. So always suspect a PID. Thank you. Thank you, sir.
Thank you, Dana ma'am. That was an excellent discussion. And can you please stop sharing? Because we have some, can we take a couple of questions, madam?
Yeah, sure.
Yeah.
Janani ma'am.
Excellent panel. Congratulations to Dhanalakshmi and all the panelists. You've done a wonderful job. I think Narmada can clarify the chat questions.
And I'll just ask the questions, madam. There has been one in, we had 100 participants in YouTube also. So congratulations to the panelists for the excellent work. And it has been, the numbers have been increasing consistently. So in one, Dr. Kausi Mohan has asked if ESBL UTI, clinically sensitive to ceftriaxone, but culture showed resistance. Can we continue with ceftriaxone or culture sensitive antibiotic, which we should choose?
Yeah, definitely we can continue ceftriaxone if there is a clinical response. But here one caveat is we need to follow up these children. They say if there is a culture discordant antibiotic, ESBL, we should not be using ceftriaxone. But fortunately, the child has responded to ceftriaxone. So this is called discordant antibiotic. If you are using a discordant antibiotic, the chance of having recurrent infection is 1/3, that is 30%. So you need to educate the parents. Suppose if the fever recurs or urinary symptoms recurs, they have to come back and have a close follow-up. So we can continue provided they should be able to come for follow-up regularly.
Yeah. So one more question, and kindly elaborate on single strength formulation. So have we to use only 5 ml is equal to 125 mg or 5 ml is equal to 250 mg? So what do we use?
We always prefer to use 5 ml is 125 mg because older children, if you tend to use 250, then it means it's a slightly older children. In that case, we always prefer tablet 250. So we use single strength 120, and older children, those who request 250, you prescribe tablet 250. The chance of dosage errors with tablets are very minimal.
Okay, I think Somasundram has already answered this question of maximum dose for azithromycin and cefixime is 1 gram. Is it for a single dose or a full day?
Full day.
So, azithromycin is a single dose only, OD dose only. So 1 gram stat, then OD dose only, it is full day.
Yeah. Then why cotrimoxazole is preferred for prophylaxis in A-gamma globulinemia or other PIDs?
So the normal bacterial.
I think we've already answered that. Yeah.
Yes, madam. I just wanted to ask for cotrimoxazole allergy. How common is it in children?
I don't have the statistics, but we should always ask the question before starting cotrimoxazole. Anybody in the family has drug allergy? This child, by mistake, whether has developed any drug allergy to any drug, then we have to be more careful. Always ask the history of any drug allergy before starting on cotrimoxazole.
I think the best thing is to educate the parents before we start them on drugs which are very prone to produce Stevens-Johnson's like lamotrigine, phenytoin, phenobarb. All these
to come back.
Make it a practice to tell them warning symptoms of SJS and tell them to stop the drug if the child develops a mucocutaneous eruption, unexplained fever or rash. I think if you tell them, educate them, we have used it for so long for UTI prophylaxis without SJS being a serious problem.
Thank you so much. I think we are. I also request Dr. Tyagarajan sir, our IMA Vellore president, join because of the number of people. So I request him to say a few words.
Hello, I am audible?
Yes, sir.
Yes.
I have to introduce myself. Though Narmada has been mentioning, I am a honorary president, Vellore branch. And it is a happier occasion to be on the Zoom on a discussing on a common problem of fever with high quality discussion. And I'm very happy to see the chair, Dr. Balasubramanian, then Dr. Yedilarasi, and IAP, TNSC, Ramesh Babu, Dr. Ramesh Babu, and panelist, Dr. Dhanalakshmi, Dr. Ashwath from Kovi Medical, Dr. Rajkumar from Madurai Medical, Dr. Somasundaram from Madar Hospital. And the discussions are going on very smoothly. And it is not only beneficial to the pediatricians, but because of its simple nature and high level discussion, it is much useful to the general practitioners, especially to the Vellore IMA members, and as well as to the specialists belonging to other branches too. And definitely the postgraduates and undergraduates, if they are attending this meet, they are also benefited. And I thank for the organizers and panelists and the IAP as well as CCB North Arcad and IMA Vellore, our branch activities. I convey my thanks and I request the program to continue. Dr. Narmada, please. Thank you.
Thank you, sir. Thank you so much.
So actually, Narmada, there are two questions in YouTube chat also.
YouTube, I think, yeah, there is one thing. If there is a culture positive entry after 2 doses of conjugate vaccine, is a booster necessary, and if so, when?
Debatable topic, actually.
Not required. All vaccines only 70 to 80% efficacy. So that's a well-known fact. I don't think giving a booster is going to help.
Cover paratyphoid.
No, if they're given unconjugated, you can ask them to give a conjugated. That you can do, yeah. See, if the child is an older child, where before the advent of conjugated vaccine, then we advise them to give a dose of conjugated. But if the child has already received conjugated vaccine, I don't think there's any point in repeating the vaccine again. I throw it open to Ashwath if you have any suggestion.
Question rather than suggestions. Ma'am, the very often question asked is when a child is recovered from a blood culture proven Salmonella enterica infection, they ask how soon after the recovery from the enteric fever the child can be given a vaccine. They feel guilty that they missed it the first time. Are there recommendations to say how many days or how many months?
Usually we tell about a month later.
It is a
month later. That's what we tell.
Culture positive enteric doesn't offer 100% immunity to the child. So we need to revaccinate. Vaccinate the child has not previously received vaccine.
Yeah.
They say an arbitrary cutoff of 1 month after the infection. 1 month after the infection. But
if they received unconjugated, you give conjugated.
Yeah.
Anything else? Any other questions?
And regarding temperature measurement, somebody has asked, is there anything to add on some temperature? I don't think we need to add on. Whatever it's recorded in Axela, you just take that as a temperature. We need not add.
No need to add.
No need to add.
I think, Narmada, I think we should conclude.
Yes, ma'am. Yeah, I have Dr. Danesh Kumar, our Secretary of Indian Medical Association Vellore, to deliver his vote of thanks. Meanwhile, Dr. Satish sir, Danesh sir, you can start. I have the virtual certificates for our delegates and panel for our panelists who have done such a wonderful work. When I get ready, I'll request Dr. Danesh sir to give his vote of thanks.
Good evening to all the dignitaries of IAP Infectious Disease Chapter. I welcome everyone. IMA Vellore is proud to be associated with IAP Tamil Nadu Infectious Disease Chapter in association with IAP CCB and NA. It was such a wonderful panel discussion on fever in children by an experienced Dr. Dhanalakshmi Madam, moderator, and the panelists Dr. Ashwath sir, Dr. Rajkumar sir, and Dr. Somasundaram sir. By sharing your experience and the importance of clinical finding and investigation and choosing the right antibiotic. So once again, I thank you, sir, for sharing your experience. And today is a great evening to have such a great educational program and enlightening the importance of the clinical examination and the investigations and choosing the right antibiotic also. I would like to thank IAP Tamil Nadu Secretary Dr. Narmada Madam for giving this opportunity. I once again thank you all for this wonderful panel discussion. With this, I will conclude this meeting. Thank you, ma'am. Thank you, sir.
Satish sir, can you please share the PPT, sir? I'm not able to share my screen. That's why. Thank you so much. We have virtual certificates for all the panelists. And Satish sir, are you able to share it now?
Thank you once again for this excellent opportunity. We had a great time.
Thank you, ma'am. So maybe I'll send it through the WhatsApp to all of you. Thank you. So if it is okay, Janani ma'am, can we conclude the session?
Conclude. Thanks to everyone. Thanks to Narmada and IMA Vellore.
Madam, there is one more question. If you are okay,
Sure. We are always okay.
In the chat, by when is 75 milligram for ceftriaxone and when is 100 milligram for ceftriaxone in Hendrix fever?
It's always 100 mg per kg per day.
It's always 100 mg per kg, right? Okay.
Yeah.
So if it is
it's
standard of 100
mg. 100, but we always prefer 100 mg per kg per day.
100 mg per kg. Thank you. Sorry for the interruption.
Yeah.
No, we are very happy because we have answered all the questions, and actually we are also having our next the CME also lined up. IAP Trichy wants to do the next program on February. So I take this opportunity to welcome you all for the next CME in February. Meanwhile, I think our first microbes edition for this year will also get released. And I also request everybody to please become members of Infectious Disease Chapter. We are posting the application form here, so that we'll have more number, and then we'll have a very great national conference too. Thank you all. Thank you so much for joining with us.
Narmada, we need more participants to be allowed next time.
Yeah, ma'am. Next time we'll get our own and we'll have unlimited participants next time.
I think so. Yeah, many people were disappointed.
I think we'll purchase the Zoom link for ID chapter separately.
Almost 76 I have seen in the YouTube link also, madam. So it's
was
100%.
No, immediately they got the YouTube link. That was very nice of them. Yeah.
So it's almost 176 delegates.
Yeah. Okay.
Yeah.
Thank you all. Yeah.
Venkateshwaran sir has joined.
Lockdown Sunday evening spent usefully. Thank you.
Thanks to all of you.
Venkateshwaran sir, thank you so much for joining. I just saw you now.
Thank you, Narmada.
Thanks, Dana. Dana, well done, Dana.
Thank you.
Venkateshwaran sir, thank you so much, sir.
Thank you all.
No more questions. Close. Yeah.
Yeah.
There is one
I
question.
think we should close. They can privately they can ask the panel.
The suprapubic, actually, what is that? Is one colony means 1,000 colony forming unit. Actually, it was misunderstood, the question. Somebody asked.
Okay.
Suprapubic sample 1,000. 1,000 is one colony.
No, there is no need for suprapubic. So
Currently
We'll
nobody
stop
is
doing invasive procedures. Please stop doing.
Yes.
yeah,
Thank you, ma'am. Thank you. It was a wonderful opportunity. Thank you for everybody.
Bye, all of you. Bye.
Bye.